1,000 patients spread over 800 square kilometres of remote highland glens and small villages. I was there for about a decade, then I went into academic practice at the University of Dundee, but I still stayed clinically practicing in one of the rural towns outside of the city. I came here in 2003 to help set up the Northern Medical Programme, and for the last 5 years I've had the privilege of leading the educational programmes for the Faculty of Medicine from my base here in Prince George. As Dermot mentioned, when my term finished in the summer of this year, me and my wife hitched up our trailer and headed north and spent the summer up in northern BC and the Yukon and in the Northwest Territories, just getting to know our amazing landscape a bit better. But while I was there, I took the opportunity to spend some more time with rural physicians and rural practices, and I interviewed a number of physicians in some of our remote practices, and also 1 or 2 nurses. And these are the real unsung heroes of modern medicine. They're very skilled people. So there's a lot of rural physicians in this room, so I'm going to tell you a story that one of the physicians related to me about what life can be like for a rural physician. And what I want you to think about is how you would handle this. And I know the rural docs can handle this, but the rest of you think about it. So you're in a remote area, you're maybe 300 or 400 kilometres or more from the nearest referral centre. You're in a small clinic, probably with a couple of holding beds and an emergency room. There's just you and 1 nurse because there's nobody else in the town at that time. And of course it's Canada, so it's snowing and the roads aren't very good. And you don't deliver babies, but you've got somebody that's in labour, and you're dealing with that. You also have a young child that you're very concerned about because they have severe asthma that's not responding. You're actually worried that you might have to intubate them. And then you have someone that's come in with an acute stroke, and you've got to get them out. Just think about you and 1 person with limited resources handling that. That's what rural physicians do all the time. Also think about what it would be like to be dealing with that and to have to spend 6 hours on the phone trying to get somebody to take your patient for you. These are some of the realities our rural docs face. I'm really impressed at what they can do and what they can do with limited resources. The other thing that really impressed me was the number of young Canadian graduates that we're beginning to see in rural areas, many of them from the University of British Columbia. So our training programs are beginning to make a difference. When I was in these practices, I said to them, so there's maybe going to be a rural chair coming. What would you want that person to do? So everyone's got a laundry list of what this chair's meant to be doing. This is what the rural doctors told me. They told me that one of their concerns is that when we're training young physicians, we're not necessarily training them for the context and the limitations of rural practice. And they weren't just referring to those young physicians who are going to be rural doctors, because believe me, they're really well trained. They were talking as much about those who will be urban specialists, because they need to understand the limitations of rural practice as well, because that's where the patients may be referred to if they're very sick. They told me how important the specialty network was for them and how important close relationships with specialists were. On the other hand, they also told me that sometimes they had great difficulty getting referral centres to accept their patients, even when there's a no refusal policy in place. They talked about bureaucracy and how the policies and procedures that are created in urban areas just don't work in rural ones. And they talked long and hard, Terry, about transport. We'll talk about that later. So what I really heard from that was what they're looking for is advocacy. And that reminds me of what's happened in Prince George in the last decade at the Europe Lecture, where Bert Kelly and the Northern Medical Society have been described as being the pebble in the shoe of government. I think the rural doctors have been saying we need the rural chair to be another pebble in the shoe, but not just of government, but of all the institutions. And those institutions are the universities, the health authority, and everybody. So that's one of the things that we will need to be doing. I'm not going to mention all the partners that have come together to make this chair happen, but I'd really like to thank them because, you know, there's a lot to do. And believe me, one person isn't going to make a difference on their own. So we're going to have to work together. We're going to have to work across all our different institutions if we want to make a difference for the patients who live in rural areas. And we can't do it just as physicians. We need to work right across the disciplines. And I'm really delighted to see one of my research collaborators here today, which is Martha McLeod. That's Martha there. Martha was the head of nursing at UNBC, and I really enjoyed working closely with her. And she's now about to be the inaugural Northern Health UNBC Knowledge Mobilization Research Chair. That's even longer than my time. And I think this gives us an opportunity. Martha is one of Canada's best-known rural nurse researchers. And it's across these disciplines that we have to work together. And so I hope that we can work together, we can build those collaborations and work together across the province to begin to make a difference. Thank you very much.